Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, in this new 3-part series from the Pumping Marvellous Foundation, we're opening up the real conversation about cardiac devices, not just what they are, but what they mean for your life. This podcast is episode 1 of 3 of a mini-series talking about cardiac devices and their role in the management of heart failure. Episode 1 is about your heart supported. What are ICDs, CRT-Ps and CRT-Ds, and why do we use them? Because drugs aren't the only first-line treatment in town. Heart failure information can sometimes feel confusing or overwhelming. The Pumping Marvellous Foundation works with clinicians and patients to produce clear, trusted resources designed specifically for people living with heart failure. No jargon, just information that helps you understand your condition and feel more confident. Search Pumping Marvellous Foundation and explore resources designed to support your heart health journey. When I was diagnosed with heart failure, what I needed was clear information and reassurance. That's why we created the Pumping Marvellous Foundation. Every day, we help people understand their condition and feel less alone. Just £5 can help us reach the next patient who needs that support. £5 may not change your day, but it could change someone else's. Visit pumpingmarvellous.org and help support patients today. Before we get into devices, can we just start with something simple? When we talk about heart failure, what's actually going on in the heart? But before we do that, can I introduce some great people in the room with me today? Over to you, Gav.
I'm Gavin Redhead. I'm a patient educator with Pumping Marvellous, and I had a device for about 15 years.
Wow. Okay.
Hi, Fozia Ahmed, heart failure cardiologist based in Manchester, and I look after people who've got heart failure and also implanted devices.
So you're a specialist?
I hope so, after 12 years.
In cardiac device
Yes.
implants.
Hi, I'm Corinne Hudson. I'm also a patient educator with Pumping Marvellous and also deputy chair trustee.
Okay, great. So I don't know who wants to take this question, but at what point does medication alone stop being enough for some patients with cardiac devices?
I guess that one would fall to me. So I think the key thing is not to see medications and devices as being two parallel pathways. If you start at the beginning and go right through to the end, patients often start on medications and two routes really. Some patients, you wait to see whether the medications have an effect and improve the heart muscle function. And if not, then you consider the role of a specialist cardiac device, either a specialised pacemaker called a cardiac resynchronization therapy pacemaker designed to resynchronize the heart, do what it says on the tin, or a defibrillator designed to monitor every single heartbeat and treat potentially life-threatening heart rhythms. That's one route. The other route is patients who it's clear from the outset that they need both a specialised pacemaker or a defibrillator at the outset, as well as medications. And which two buckets patients fall into, or which two routes you need to follow, depends on the diagnosis, the severity of their condition, the severity of their symptoms, and often their ECG as well.
What are the signs that you're looking for? Are they all clinical indicators, or are they the signs and symptoms of heart failure?
Typically clinical indicators. So you have to, in order to be able to treat an electrical problem, there has to be an issue to resolve or to correct. So whether that's heart muscle function that's severely reduced and not improved after medication, that might be the role of an ICD, a defibrillator. And for patients who might need a specialised pacemaker, that's typically that you look at their ECG, it shows that there is delayed conduction. So there's delay in the electrical activity going from the right side of the heart to the left side of the heart. And in those cases, they may benefit from a specialised pacemaker, and that might be evident from the outset. You may know that even if you give this patient medications, they're still going to have this problem at the end, and that will need correcting. So the timing of those discussions varies between patients. You might discuss it right at the beginning, or you may wait to see the effects of medication.
So, it sounds pretty overwhelming. And I know it's really, on the community, people, on our Pumping Marvellous Foundation community, people say, I've been told that I need a device, and there's a huge conversation starts about people's lived experience. But how do you explain the electrical side of the heart to patients without it sounding
Yeah, it can be overwhelming. And I think one of the things that we've still not got to grips with is how to break down that conversation into bite-sized chunks and have it at the right time. You could front load the whole conversation at the outset, but that's overwhelming and may not be necessary for everybody. Probably the most straightforward approach is to explain they've got heart failure. We're probably going to start with medications, reassess heart function, see if it improves. And if at that point the heart muscle function's not improved, start to have conversations about devices.
So are we talking about an engineering thing here? It's a little smile. What was the smile for then?
Well, we try to get away from medicalizing discussions, but actually engineering, are we also making it technical again? So I don't know how we humanize the discussion. I guess that's my key.
You sort of can't call it a sparky conversation, can you? Like an electrician, but it is very. I mean, it's very different for somebody to take a tablet compared to something that actually lives. It's a 24/7 resident with them, and has such a profound impact. I mean, we'll get on to speaking to Gavin Corrin in a bit, but very shortly. People name them and they give them personalities, and it sounds like because it sounds structural.
Yeah,
it's an engineering thing, and you're right. We medicalize heart failure is very medicalized because it's relatively complex.
Yeah.
Engineering. Well, so Gav, when you were told you've had a device for 15 years.
Yeah.
When you told you were needed, when you were told you needed it, what went through your mind?
I mean, I'm in the unusual, probably fairly unusual. I didn't get the device as part of the heart failure therapy. I already had, I'd lived with hypertrophic cardiomyopathy, and I had developed some of these dangerous rhythms, these arrhythmias, and I was at risk of sudden cardiac arrest. So in 2009, I had that initial discussion, and it's quite a shock, and it's a strange word, probably not to the system. It's quite daunting to be told that you're going to have a device put in. And there's the initial thing about, well, how big an operation is this? Because anything to do with the heart, and they're talking about putting something in your chest, you're thinking, how big is this? How big an operation is this going to be? And that side of it actually is probably not the worst side of it. I think that's probably the easiest in some respects. It's a very simplified procedure; it doesn't take very long. But the actual mental side of it is probably the more daunting side of it. I think so what you're telling me is you're going to put a device in my body that if I get one of these dangerous arrhythmias, it's going to give me a shock. And you see these televised shock therapies happening on TV with the external defibrillators, and you think that's what's going to happen from the inside. You're going to be jumping up and down, and that is in your mind. You could be driving along, and that's going to happen. Does that mean I'm going to crash my car? So I think the mental side of it is a more daunting experience than the actual operation itself and having the device implanted.
Yeah, I'd love to hear from Corrin in a second, but I think you've made, opened my eyes a little bit. We often think about the procedure and talk about the risks and benefits of the procedure, but what we talk about less, because we assume that the nurses will do it to an extent, and the cardiac physiologist will also have that discussion, is living with the device. And actually that's perhaps something that we see less of, because we see patients for 30 minutes a year, and they're with
it. You put it in.
Yeah, we
you
put
wish
it
them
in.
all the best. They say it's going to be monitored.
And then they're remotely monitored, and then you don't see them till their next clinic appointment. But it's the person that's living with this at home.
So how did it make you feel when you were told you needed one?
I was going back to what Fozia just said. I was in the sort of team of people where it was part of diagnosis, medication, and pretty much straight away you're going to need some kind of device. My initial thought, ridiculously, was that I'm going to wear this huge thing on my back, because I had the visions of the sort of the case of although it was a ridiculous thought, that's kind of where my head went. And then obviously, you ask questions and you find out more, and you realize it's obviously something that's quite small and there's going to be an operation. I think that it all happened quite quickly for me. sort of diagnosis, medication, you're going to need a device. That I think that all of that, I almost didn't process it, if I'm honest. I think it was afterwards, after the operation, when, obviously I needed to be still and
Were you
sort of and
sedated
heal.
or?
I wasn't, not a general, but I had, I sort of had an awareness of it.
Yeah.
I can vaguely remember, it was almost like being in a dream state. I vaguely have a recollection of conversations that were happening around me and also to me. It was quite bizarre in that way, but not horrible at all. It felt very relaxed and very, just very controlled and very calm. It felt a nice environment to be in.
Do you feel that because you were moving on from medication to a cardiac device that you're going to be in a pickle?
I think that it gave my diagnosis a sort of an enormity to it, I think, and a significance to it. Whereas I think that because prior to that, it had almost been like a drip feed of, it's this, and then there wasn't really a moment where the word heart failure was used specifically. It gave it like almost like not a finish line, but sort of like a line in the sand almost of something happening. And I think particularly after it was fitted, I then processed what had just happened over the last sort of few weeks or months or whatever. And it gave me, because I needed to recover and sort of look after myself and be still and, what have you. It gave me that pause almost, because I had to, and I had to think it all through.
So we are talking about this here, which is a ICD, which is an implantable cardiac defibrillator. So there's that little box there that fits in a pocket here. Is that right, Fozia?
I'll have to have a look.
No, it is.
Oh, right, okay.
I was just saying, in a little pocket here. Then this one is a cardiac resynchronization, an ICD. So this one paces your heart, but it also is an ICD. So it has two functions or functionality, or more than two functions of functionality. And then you've got a slightly thinner one, which is a CRT-P, which is just the pacing one, which is smaller. And then you've got this one here, which is what's this one? This is another one. I think that's a 3-lead. What will that be?
CRT-D.
CRT-D. So that's another CRT-D. So very similar to this one, just two different manufacturers. So this is what we're talking about. We're talking about these little boxes of power that help people live better with heart failure. So Fozia, what is an ICD? What is a CRT-P? And what is a CRT-D? And what do they all do?
Okay, no, that's great. So if we unpack, probe it, and just pick at the bones of it a little bit more. If we start with a defibrillator, just because perhaps that's where many people start. This is a device. The simplest way to think of it is that we don't get car insurance on the expectation that we're going to go out and crash our car. Bear with me. It's a form of an insurance policy. It's there if you need it. You may never claim on your car insurance, but if there's ever a problem, it's there. And I think a defibrillator, we need to see as a similar kind of, one way of framing it is a bit of an insurance policy. It's there, it sits in the background. Okay, it's there physically. But what it does is most often it consists of a single lead that's placed in the right side of the heart through a vein at the top of the chest. And that lead, when combined with a defibrillator with a battery that sits underneath the skin, it monitors every single heartbeat that goes out. And if no problems are detected, then you'll just go through your life and your battery will be changed at 10, 12 years when it's depleted. In other cases, if your defibrillator detects an abnormal heart rhythm, it will first watch. It will watch and wait to see whether or not your own heartbeat restores back to normal. If it doesn't, and if the heart rhythm is particularly life-threatening or very, very fast, then it will try to deliver extra beats to try and break that circuit. So throws in extra beats to try and restore your heart back to a normal rhythm. That's called ATP, anti-tachycardia pacing, and people have got defibrillators.
Tachycardia is, high heart rate.
Fast heart, yeah, and it's delivering extra beats, typically 8 beats, that delivered faster than the abnormal heart rhythm to try and break the circuit and restore normal heart rhythm. And it can try that a couple of times. That's usually painless, so patients don't feel it. It's a way of avoiding shocks from the device. But if that's ineffective, or if the heart rhythm is particularly dangerous or very, very fast, then your device will deliver a shock. But by that point, people are typically either not feeling very well or maybe passing out. So sometimes people aren't aware that they've had shocks.
It's an onboard paramedic.
Yeah. It's your own personal defibrillator that walks around with you rather than having the big machine at the side. And that's a defibrillator. A defibrillator can be combined with a specialised pacemaker, or it can be on its own. A specialised pacemaker, so cardiac resynchronization therapy, does what it says on the tin.
Sounds very complicated, that.
Yeah, I guess
it's not really. Is it a pacemaker or is it?
It's a specialised pacemaker, so It's a bit more than a regular pacemaker. A regular pacemaker, you've got one lead in the bottom chamber of the heart, the right side of the heart, sometimes a lead in the top chamber of the heart on the right-hand side. But then that's paired, a regular pacemaker is paired with a lead that goes on the left side of the heart. So now, typically in people with heart failure, you've got a lead on the right side, lead on the left side. When that's connected to a specialised pacemaker, CRT, heart resynchronization therapy, cardiac resynchronization therapy. It's designed now to cause both the right and left sides to contract at the same time to restore normal heart muscle structure and function. And what we see is that over time, some patients, their heart muscle function, once it's resynchronized, normalizes. In other patients, it improves, but not quite back to normal. And in the other group of patients, we may see either that the rate of decline slows or that they're called non-responders. And
so the non-responder percentage is what, 30%?
Yeah, it's getting lower. It used to be around about 30%, but now
Why is it getting lower?
Because as technology's evolved and developed, we've been able to develop, well, not we, manufacturers have developed new leads, better algorithms that can pace using the same lead, different parts of the heart. And so it can try different positions to get a better configuration.
And there are wireless, aren't there?
There are wireless
ones.
Work? Yeah, so that is like a rice grain that's inserted into the left side of the heart, directly into the left ventricle. And then it uses kind of a signal to connect back with the battery. Combined with a regular pacemaker, it causes the heart muscle structure and function. It causes the electrical rhythm to be resynchronized. They're not used as much in the UK. Trials have recently finished. At the moment, we're still on leaded devices for the majority of patients when you're going to be having those discussions.
It's time for a marvellous myth buster, busting the myths around heart failure. Myth: heart failure is uncommon.
Truth: heart failure affects around 1 million people in the UK, and many more may have early or undiagnosed symptoms.
So my device was a dual lead ICD.
Yeah.
So it had a pacing function and it had a thing. So it had 2 limits set. So it had a lower limit set. And I think the first one I had put in was put in at 40, but my heart rate, I was feeling too ill because it was dropping to 40 and then pacing. So they put it up to 50. But then it had the higher level, which was, I think it was 180, something like that. And that was when it detected, if it went above 180, that's when it would start to deliver that CRT-P therapy.
Yeah, so the benefits of having a defibrillator, that all defibrillators can function as a pacemaker. The downside is that sometimes people have a tendency towards a slow heart rhythm, and rather than the pacemaker in the bottom chamber being activated, you want it to be more what we call physiological. So you'll have an atrial lead in at the same time. So you've got a 2-leaded system, lead in the top chamber of the heart, lead in the bottom chamber of the heart. What that allows us to do is people who've got a tendency towards a slower heartbeat, where they still need medications to stop the abnormally fast heartbeats, it gives us a little bit more confidence to be able to increase medications without causing you undue symptoms or the pacemaker to work too much.
Right. So, Corinne, if you were Fozia, how would you explain it to a patient who needed a device? What would you say?
Oh,
that's a bit of a tough question.
It is. It's really hard. Yeah, no, I would.
I'm interested in this one.
I would say it's it's there as as a just in case, but it's also there to support the drugs as well and to help with those therapies too. But it also it's there for peace of mind as well, and it's peace of mind, I guess, for both the cardiologist and also the patient, because it gives that backup. From a patient perspective, I absolutely love having mine. It actually, I feel like I've got sort of like an electronic connection to the hospital at all times. It feels that kind of, and if it feels sort of really positive to have it, and to know that potentially there's sort of people in a room taking away, sort of monitoring my heart. It feels really very reassuring. So
this would be really good for Fozia, because she have like an Obi-Wan Kenobi moment. You're my only hope, and you could bring a 3D render of Corinne or Gav, and they say, "Oh, just listen to this."
But I think that's important. I think understanding that there's not just the device, there's the monitoring station.
Yeah.
You can have a standalone monitoring station next to your bed or in the room somewhere, but you also can have it on your phone, can't you, as a connection? There has to be a connection in some way through the telephone system to the hospital. And in terms of picking up irregular rhythms, or if there's any I know Corinne's had an issue with one of her leads recently, so that notification, so that hasn't come from Corinne saying I've got an issue. It's come from being picked up.
Yeah, remote monitoring has radically changed the way that we deliver care for people who've got heart failure and a cardiac device, or just people who've got cardiac devices. But if I pick up on 2 points, I really like what you said about the medications and the device working together. You're absolutely correct. We know that if you think about those specialised pacemakers, one of the key reasons why they don't work as effectively as they can is because patients aren't on good doses of foundational treatments that have got proven benefits to improve heart muscle structure, function, symptoms and outcomes. So yeah, the two things are very much synergistic or work together. But yeah, remote monitoring has transformed not just the way that we deliver care in a hospital setting, in that people don't need to just come in for the checks.
We're going to cover that in depth in episode 3, aren't we?
Oh, I didn't know. Sorry.
No.
That's more the advanced.
We're going to cover that in episode 3.
But when you actually turn up at the hospital for you do regular check, 6 monthly standard?
Yeah, it's reduced in frequency now. So you can do something called alert-based monitoring, which we'll cover in episode 3. But yeah, typically yearly. But some patients are able to discharge to remote-only monitoring if there's no issues. And then they'd have for example, if they're seeing another cardiology clinic or a heart failure clinic, those appointments would continue as usual.
Because that's a strange situation, isn't it? When they put almost like a computer mouse over the top, and then say, any second now I'm going to start speeding it up, and you feel your heart, you sat there completely still, and your heart is going like you're doing a marathon. Yeah,
it's when they slow it down.
So for the healthcare system, is this about survival, or is it about quality of life for patients?
You mean the device or the remote monitoring?
Yeah, offering the device. Yeah, I know we're still on remote monitoring. Episode 3.
It's about improving outcomes for patients or for people who are living with heart failure or with a cardiovascular disease. So it's about improving outcomes, reducing premature death.
But is that like seen by the patient as the last resort?
It should. If we're seeing it as a last resort, then we're delivering. Perhaps we've missed the opportunity to diagnose and treat them at an earlier time point.
And is that okay? Here's a big question for you.
Yeah,
I know it's on the lips of a lot of people. Are they offered not too late, but should they be offered earlier?
So we know that in the UK we under implant based on what the implantation rate should be, if we compare it to the rest of the world and to Europe. And within the UK, there are hot and cold spots. There are areas that do really well, where devices are considered in every patient all of the time. And we've got other areas where perhaps they lag behind, and whether that's just the makeup of the team or the expertise in the team or access is unclear.
In my experience, it's very much about the makeup of the team. Because if you've got a Fozia in each of your teams, you will be considering the appropriate patients with the appropriate device?
Yeah, you've got to think about what teams look like. So has everyone in the team been upskilled to think not just about medications, but about devices, either as devices at the outset in some patients who've got inherited cardiac conditions where their risk of heart rhythm problems is calculated to be high, so they should have one irrespective of what their heart muscle function is, or in those patients with whom, like Corinne was describing earlier, diagnosis, medication, assessment of the heart muscle function, actually we still have room to further reduce your risk of events by offering you a device.
So
risk assessment is probably where we fall down. We don't do it in a, my biggest gripe, the NHS is fantastic. We're a single payer, single provider healthcare system. Everything goes around in a circle. Yet, even between hospitals, we have different policies and protocols and pathways. And even within the same department, we do things differently.
So when you get down to the granular level, it's very different.
We need to be like a biscuit factory or a widget making factory where everything is standardized.
But don't people, that's what I would assume that is, we are, because the NICE guidelines and, the overarching guidelines and technology appraisals for medications and the MedTech Pro, the whole NICE thing, isn't that supposed to level the playing field?
We have great guidelines. We have great evidence. The problem is that implementation varies widely. Things are implemented, whether it's medications or whether it's devices, variably or sometimes not at all. And that's the problem. It's the human factor of implementing these things.
So these are really important therapies. Not many people know about them. So how do we involve? So it's one of the big questions that we have, and we try and cover in our booklet, but I think we could do a lot better, is how do we involve patients in the decision-making? Because of I don't know whether the viewers and the people listening know this, but you need to have informed consent. So informed consent is in real brass tacks, is the patient needs to understand what's happening and the risks and everything there, before they get a piece of paper said, sign here on the dotted line with all the blueprint and the small stuff. And it's the healthcare professional's responsibility to deliver that message and discuss that with the patient before they say yes or no. So, Gav, what do you think is the optimized way of involving patients in the informed decision-making process? It's a bit technical. I don't like it. It's a bit...
I think at initial diagnosis, and Fozia alluded to it earlier, there's so much information, it's very sort of overwhelming into just the term heart failure. Heart failure.
Do you think it's a bit
death.
sketchy?
Isn't it? Yeah, people, heart failure, death. They confuse it with heart attacks, confuse it with cardiac arrest, etc. So the terminology isn't great. But I think once you've built that relationship, as long as you get to see a familiar face for at least the first few months, and whether that's your heart failure nurse or whether that's your specialist at the hospital, your cardiologist, I think once you build that relationship, I think it's introducing that, even if it might not be something that's going to be offered, you're not going to be offered device therapy in the next few months, have that conversation to say, this is somewhere along the line, we may get to a stage where medication might not be enough.
Do you think that's a failure of the system where we don't talk about what could be?
Yeah.
Do you think it's a bit, if I tell the patient that this is an option, and then they come back to me in 18 months and say, why haven't you implemented this with me? Do you think that's a difficult, or am I wrong?
I think as long as it's clear at what stage that will be, will be implemented. So we're not going to do it, as long as you start responding to the medication therapy, and that's fine, and things seem to be improving or stabilizing as a minimum, then I think it's fine to talk about it, but say not yet, and the reasons why. I think as long as we have that conversation and we're involved in that decision-making process, I think it would not be correct if we were to have that conversation and then it was appropriate that you should be having that device, and then some kind of cost-benefit analysis comes into it, as opposed to somebody's risk-averse.
So what's your reflections on what Gav said, Corinne?
Yeah, it's almost... It's being able to sort of say to the patient, this is a situation that you find with your heart now. This is what we found out, and the reasons why it is as it is. these are the tools that I've got. I've got this tool, I've got the medication. There's variation with that. There's a few tools in there that can be tweaked, and there's other things. We've also got device therapy as another tool. And if, and that should, help in this way. But if not, then there's other, and it's about if it's appropriate for that patient, showing all those tools, if that makes sense, to reassure them that, it's not that things are failing. It's just that it's not quite working for whatever reason, and it's tweaking it as it goes along, isn't it? Yeah.
So, Fozia, sure.
Yeah, I was going to jump in. I think if we, heart failure, cardiovascular disease, I always see it as a bit of a poor man's relative to,
other stuff.
Things like, if we think about cancer, if you think about there isn't a person not walking around that isn't familiar with the fact that if someone is diagnosed with cancer, you need to diagnose it early. You need to start treatment promptly. That treatment may look like chemotherapy, radiotherapy, surgery. There's been so much socialization of that, whether it's through the media, on podcasts, on the TV, and as news stories. Yet maybe we could continue to spread the messaging about things like cardiovascular disease. If we think about our last day on this earth, many people, the commonest cause of demise is cardiovascular disease or cancer. So being a little bit more, or being better informed about how to reduce risk, how to live longer, how to live better lives and fewer symptoms. I think we do need to start talking about, when it comes to the management of cardiovascular disease, medications, procedures, whether that's stents for furring up of your heart arteries or a defibrillator if you're part of, or a pacemaker, we could do a better job of socializing that. So the first time that a person hears it is not when they're in the clinic.
Right. And that's why people don't understand. I mean, I didn't know what heart failure was. I had a heart attack and cardiac arrest, but I didn't know what heart failure was when somebody told me.
Yeah.
So I thought, that must be. Right, okay, I'll have to look that up. So I'm going to ask a question to everybody. If somebody's listening right now who's been told they might need a device, Gav, what would you say to them in a one-liner?
Yeah, don't be afraid. Just, accept that it needs to happen, and it's going to be for the your benefit and your family's benefit, better quality of life.
Fozia?
Yeah, I think arm yourself with all the information needed to help you make an informed choice. Speak to people beforehand, feel relaxed about it. Hold the dummy devices in your hand when you go to your pre-admission clinic. But also use it as an opportunity to tell your family members about the fact that I've got patients who don't want anyone to know. And they'll say, can you put a scar here on the side? Yeah. Are you going to tell your wife? No. I was like, okay. So I think there's still a stigma with having a cardiac device that it might represent a failure of therapy, that the medications haven't worked. We need to reframe how we see it. They're just part of the management of cardiovascular disease.
I think that's really important. I think that's reframing is really, really important. So Corinne, give us your one-liner.
I would say don't hesitate in as much that I think it's for me, it's been a really, really positive, experience, and I really like having it, and I find it, very reassuring to have it, my little on board.
Have you got a name for it?
I call my I can do for the ICD, so it's enabled me to do things. So I can do things that
Gav,
maybe haven't.
Did you ever?
No, I never got round to naming mine. I missed an opportunity there. I had 3 and I missed. They're all without names.
So it's been a really interesting, insightful discussion, which hopefully people will gather a lot of information. Certainly, if they're in the space for having an ICD or a CRT-D or P, from one of these little fellas, little tiny little things here, and I'd like to thank you for joining me on this excellent podcast. And I think people need to listen to podcast 2 and podcast 3 in this mini series about cardiac devices. Thank you.